Welcome to Test of Time, a series that revisits the trials that changed how we practice and asks one question: do they still deserve to? Today, a genuine landmark in surgical oncology, the CROSS trial, published in the New England Journal of Medicine in 2012 from a Dutch national collaboration led by Van Hagen and colleagues. It is the trial that made neoadjuvant chemoradiotherapy, followed by surgery, a standard of care for oesophageal cancer across the world. Its claim to fame is easily stated. In a disease where surgery alone gave most patients only a 1 in 3 chance of long-term survival, a short, well-tolerated course of chemoradiotherapy before surgery roughly doubled median survival, from 24 to 49 months. That result and the regimen behind it entered guidelines within a couple of years. Our task today is to understand why it was believed and then to follow it forward through the decade that came after. In brief, 366 patients with resectable oesophageal or junctional cancer, 3/4 adenocarcinoma, just under a quarter squamous, randomized to chemoradiotherapy, then surgery, or surgery alone. The chemoradiotherapy was weekly carboplatin and paclitaxel with 41.4 Gray of radiation. The primary endpoint was overall survival, and the hazard ratio was 0.66 in favor of the combined treatment. Here is the whole story on one slide, and it is the shape of every test of time. Before CROSS, surgery alone and real uncertainty about whether anything added actually helped. The trial, chemoradiotherapy then surgery in 366 patients. And after, a doubling of median survival and a new worldwide standard. The rest of this episode fills in that middle and then tests whether the after has lasted. To judge the trial fairly, we have to stand where its authors stood, in the early 2000s. Oesophageal cancer was, and remains, a serious diagnosis. Even after a complete resection, 5-year survival sat around a third to 40%, and most patients relapsed. Surgery alone was the accepted standard in much of the world. The field wanted to do better, but it did not yet know how. And the prior evidence was genuinely conflicting. Walsh in 1996 suggested a benefit, but in a small trial that drew criticism. Bossett, a year later, found none. An American trial, CALGB 9781, favored chemoradiotherapy but closed early, badly underpowered. Meta-analyses hinted at a benefit, a hazard ratio around 0.78, that no single trial had shown convincingly. There was, in the truest sense, equipoise. A well-powered randomized trial against surgery alone was exactly the right instrument. So to the methods, because for a landmark, the methods are the point. First, the population. Resectable, non-metastatic oesophageal or junctional carcinoma, staged with CT, endoscopic ultrasound, and later PET. Both major histologies were included, with histology pre-specified as a stratification factor and adenocarcinoma predominating, which reflects the Western pattern of the disease. Clean contemporary staging and clear criteria gave a generalizable surgical population. Randomization was 1:1 with allocation concealment stratified by histology, performance status, and center. Now this was a trial of surgery plus radiotherapy, so it could not be blinded. Ordinarily, that is a concern. But here the primary endpoint was overall survival, an objective outcome that does not care whether the assessor knew the arm. So the open label design, which would weaken a softer endpoint, carries very little weight against death from any cause. The intervention itself was deliberately gentle. Weekly carboplatin and paclitaxel with 41.4 Gray, a dose chosen to be effective without wrecking the operation that followed. And it worked as designed. Over 90% of patients completed the full chemotherapy and radiotherapy. The comparator was surgery alone, the standard when the trial was designed. Hold that comparator in mind. We will come back to it because it is central to how the trial has aged. Overall survival was a primary endpoint, a hard outcome. Secondary endpoints included complete resection, pathologic response, and safety. The trial was powered for the combined population and analyzed by intention to treat. A hard endpoint, an honest analysis set, adequate power, these are the unglamorous features that made the field trust the answer. Put together, the methodology reads as a series of strengths: concealed stratified randomization, an objective endpoint that survives the open label design, a tolerable reproducible regimen, and, as we will see, follow-up that matured to 10 years. The one item to flag for later is simply the choice of comparator, surgery alone, which was right for its era. Now the results, in the order they unfold. First, local control. A complete R0 resection was achieved in 92% of the chemoradiotherapy patients against 69% with surgery alone. And a complete pathologic response, no tumor left in the specimen, occurred in 29% overall. But notice the split already. 49% in squamous cancer, 23% in adenocarcinoma. The two histologies were behaving differently from the very start. And then the headline: median overall survival of 49.4 months with chemoradiotherapy against 24 months with surgery alone, a hazard ratio of 0.66. A few weeks of treatment, roughly doubling median survival in a disease that rarely offers such gains. That is why this trial became a landmark. Crucially, the benefit came at very little cost. Postoperative complications and in-hospital mortality around 4% were no higher in the chemoradiotherapy arm. Hematological toxicity was modest. A treatment that helps substantially and harms little is exactly the kind that changes practice quickly, and this one did. But a landmark has to last, and the cross investigators did something many trials never do. They kept following their patients. At a median of 7 years, Shapiro confirmed the benefit held, hazard ratio 0.68. At 10 years, Ike reported 38% alive with chemoradiotherapy against 25%. The curves had not converged. Durability here was not assumed, it was measured, and it held. It helps to see the whole effect at a glance. Across the primary report, the 5-year update, and the 10-year update, the hazard ratio sits remarkably steadily around 0.7. The benefit did not fade with time. But split it by histology and the divergence appears. A hazard ratio of 0.48 in squamous cancer against 0.73 in adenocarcinoma. The same trial telling two rather different stories. A divergence we are about to follow into the years that came after. The effect on practice was swift. The carboplatin paclitaxel 41.4 gray schedule became simply the cross regimen, a named reproducible standard written into the NCCN and ESMO guidelines for both histologies. For much of the following decade, it was the default answer to the question, what do we give before an oesophagectomy? So where does a fair, respectful reading push back? 5 points, each judged by the standards of its time. First, the trial pooled two different diseases, adenocarcinoma and squamous, for its primary result, with adenocarcinoma 3/4 of the cohort. In 2004, combining histologies was standard and pragmatic, and the trial did pre-specify and stratify for histology. But later follow-up shows the benefit is larger and more durable in squamous disease, so the single pooled figure understates one and overstates the other. That is precisely where the story would later divide. Second, the comparator. The control arm received no systemic therapy at all. Now that was entirely fair in 2004. Perioperative chemotherapy for adenocarcinoma was only published in the MAGIC trial in 2006. But against surgery alone, the bar is low. The question that mattered later, is chemoradiotherapy better than modern chemotherapy, is one Cross was simply never built to answer. It was left for the trials that followed. Third, the setting. The trial ran entirely in 8 Dutch centers. That is not so much a weakness as a design choice. A rigorous, quality controlled national trial is exactly what made the result trustworthy. The fair caution is about generalizing to systems with different surgical volumes or radiotherapy quality. But real-world cohorts since have largely reproduced the benefit, which is reassuring. Fourth, the radiotherapy belongs to its generation, 41.4 Gray, with the conformal techniques of the time. That was appropriate and deliberately restrained to protect the operation. Technique has since moved to IMRT, and the field now even debates whether radiotherapy is needed at all in adenocarcinoma. But the Cross regimen itself remains well tolerated and easy to reproduce, which is part of why it endured. And fifth, a subtler point. Cross produced an excellent pathologic response, especially in squamous cancer, a meaningful signal. But as we are about to see, a later trial showed that this superior pathologic response did not translate into a survival advantage over chemotherapy in adenocarcinoma. A good reminder that a surrogate endpoint is a clue, not a verdict. Which brings us to the real test. What happened next? 3 trials define the legacy. Neo-AEGIS in 2023 compared Cross against perioperative chemotherapy in adenocarcinoma and found them comparable. 3-year survival of 57 against 55%. Checkmate 577 in 2021 added adjuvant immunotherapy on top of the Cross backbone and doubled disease-free survival. And ESOPEC reported in 2024 compared Cross head-to-head against perioperative FLOT chemotherapy, and FLOT won, with median survival of 66 against 37 months. So, has it stood the test of time? The honest answer is split, and that split is the lesson. In squamous cell carcinoma, Cross stood decisively. The benefit is largest and most durable, and it remains a standard. In adenocarcinoma, its primacy has given way. Perioperative chemotherapy is at least equivalent, and FLOT now appears superior. And it was extended, not overturned, by adjuvant immunotherapy for residual disease. A landmark that changed the world, held for a decade, and was then surpassed, in one histology, by the very kind of trial it made possible. For the resident at the bedside today, that resolves into 2 clean reads. For squamous cancer, cross-style chemoradiotherapy remains a standard neoadjuvant approach. For adenocarcinoma, perioperative FLOT is now the preferred option on current evidence, with chemoradiotherapy reserved for when chemotherapy is unsuitable or radiotherapy is specifically needed. And the take-home, beyond this one trial, a landmark is not a monument, it is a measurement, taken at a moment that the field keeps retaking. Cross was right for its question and its time. Reading it well means holding 2 truths at once, that it genuinely changed the world and that the world it changed has since moved on where the evidence has moved on. Revisit the classics with the same care you give a new paper, and let the later evidence, not nostalgia, deliver the verdict. That was the Cross trial, a landmark weighed by the years since. Thank you for watching Test of Time. Read the next classic with the same care.